Hello, Bashir.
హలో
ఇది యాక్చువల్గా మళ్ళీ స్లైడ్ షో అవ్వట్లేదండి. కెన్ యూ హెల్ప్?
ఒకసారి ఓపెన్ చేయండి, లేకపోతే ఓపెన్ చేసి రైట్ సైడ్ లో పర్సంటేజ్ ఎక్కువ చేసేయండి, అయిపోతుంది. స్క్రీన్ షేర్ చేయండి ఫస్ట్.
ఓకే, స్క్రీన్ షేర్ చేస్తున్నాము.
అక్కడ కింద పర్సంటేజ్ ఉంది కదా, అది ఎక్కువ చేసేయండి.
ఓకే, ఇప్పుడు వస్తుందా?
సేమ్ అదే వస్తుంది. పర్సంటేజ్ ఎక్కువ చేసేయండి అంత.
ఓకేనా?
కొంచెం తక్కువ.
కొంచెం తక్కువ. ఓకే, ఇజ్ ఇట్ ఓకే?
చాలు చాలు, కొంచెం ఎక్కువ. చాలు. ఒకసారి వ్యూలో పోండి, వ్యూ
1 minute.
పైన పైన పైన
ఓకే, వ్యూలో
స్లైడ్ షో అని ఉంది చూడండి, పైన పైన బటన్ లో, యానిమేషన్ పక్కన
స్లైడ్ షో అయినా అలానే వస్తుంది.
ఫస్ట్ది కొట్టండి, ఫస్ట్ది ఫ్రమ్ బిగినింగ్ అని.
అయినా సరే అలానే వస్తుంది.
ఓకే మేడం, కంటిన్యూ చేయండి.
ఓకే, ఫైన్.
Good morning to all, sir. Today we are going to discuss about diabetic autonomic neuropathy and tests, sir. Diabetic autonomic neuropathy. Diabetic neuropathy is defined as the presence of symptoms and signs of nerve dysfunction in people with diabetes after all other probable causes are excluded. Risk factors for the development of diabetic neuropathy. There are two types of risk factors: modifiable risk factors and non-modifiable risk factors. In modifiable risk factors, poor glycemic control, hypertension, smoking, alcohol, and hyperglycemia are the hypertriglyceridemia are the modifiable risk factors. And non-modifiable risk factors are obesity, older age, duration of diabetes, family history of neuropathic disease, and Aldo's rectus gene hyperactivity. There are the types of diabetic neuropathy are sensory motor and autonomic neuropathy. In sensory motor type, acute reversible and permanent types are two types. In acute reversible type, due to hyperglycemia, transient neuropathy occurs, which is reversible. And in permanent type, there are two types: symmetrical and focal and multifocal. In symmetrical type, there is acute sensory neuropathy and chronic sensory motor neuropathy. In focal and multifocal type, mononeuropathy, polyneuropathy, small fiber neuropathy, large fiber neuropathy are present. This diabetic neuropathy is itself a large topic, but we are not discussing deep into that topic. We are discussing about the tests required for the assessment of the diabetic neuropathy. Autonomic neuropathy is the other type of neuropathy in which gustatory sweating, postural hypotension, gastroparesis, diabetic diarrhea, neuropathic bladder, Charcot arthropathy, and cardiovascular autonomic neuropathy are the main concerns. The pathophysiology of the diabetic neuropathies: in diabetes, nerve glucose is increased due to hyperglycemia. The neural degeneration and progressive impairment of regeneration, especially thin myelinated fibers, occurs. Neural damage is caused by hyperglycemia, which causes activation of polyol pathways and synthesis of advanced glycation end products, excessive activation of protein kinase C driven pathways, and microangiopathy of vasonervosum. Oxidative stress and alterations in nerve blood flow are also factors of the pathogenesis. Due to these changes, Schwann cell dysfunction occurs due to primary demyelination. Secondary segmental demyelination due to impairment of axonal control of myelination, remyelination, and Schwann cell proliferation. Atrophy of denerved bands of Schwann cells and basal lamina hypertrophy, sir. It's a spelling mistake, sir. It's a basal lamina hypertrophy of the Schwann cells. The various tests for diabetic autonomic neuropathy. Autonomic neuropathy is of early stage, intermediate stage, and late stages. In early stages, abnormality of heart rate response due to deep breathing alone is present. In intermediate stages, abnormality on Valsalva response, and in late stages, presence of postural hypotension is present. Diabetic neuropathy importance in anesthesia is the presence of cardiac autonomic neuropathy alters the hemodynamic response to induction and tracheal intubation during general anesthesia, resulting in intraoperative hypotension. A thorough preoperative assessment is necessary for monitoring perioperatively and ensure successful anesthesia management and decrease in morbidity and mortality. Not only in general anesthesia, the autonomic nervous in epidural anesthesia and in spinal anesthesia also, the autonomic nervous tone is inhibited by both epidural, spinal, and general anesthesia. In epidural and spinal anesthesia, the shift is towards sympathovagal balance, towards sympathetic predominance. In general anesthesia, it is parasympathetic predominance. So, assessment of the degree of autonomic neuropathy is important for effective anesthesia management and to decrease intraoperative and perioperative morbidity and mortality. The tests for parasympathetic control are heart rate variability in response to deep breathing, standing, and Valsalva maneuver. Valsalva maneuver is influenced by both sympathetic and parasympathetic. Now we are discussing about parasympathetic control. Heart rate variability on deep breathing, general respiratory sinus arrhythmia is present. It is a normal phenomenon in which heart rate increases in inspiration and decreases in expiration due to vagal input to the sinus node during expiration. Normal variability is greater than 15 beats per minute. In autonomic neuropathy, this autonomic neuropathy decreases the difference between maximum and minimum heart rate during respiratory cycle. In autonomic neuropathy patients, the variability is less than 10 beats. If the variability is less than 10 beats per minute, it is abnormal variability. It occurs in diabetic autonomic neuropathy. Another phenomenon on standing, rapid increase in heart rate occurs on standing and response is maximum after 15th beat after standing, and relative bradycardia occurs after 30th beat after standing. The ratio between the longest on ECG, the ratio between the longest RR interval during 20 to 40 beats, most approximately it will be 30th beat, to the smallest RR interval during 5 to 25 beats, it will be approximately 15th beat. The normal ratio is 1.04. If the ratio is less than 1.01, it is considered as abnormal. In diabetic neuropathy, there is only a gradual rise in heart rate. This variability is not present. On Valsalva maneuver, the heart rate increases and on release, heart rate decreases. On Valsalva, intrathoracic pressure rises, which causes intravenous, inferior vena cava compression. Due to this, the blood is emptied into the right atrium. As a result, initial transient increase in venous return is present, followed by decrease in venous return occurs. Decrease in cardiac output causes heart rate occur, and heart rate gets increased to maintain cardiac output. As the heart rate is increased, this is the shortest RR interval. Vasoconstriction also occurs to increase the BP. After release of Valsalva, venous return becomes normal, cardiac output becomes normal, but vasoconstriction is still present. As a result, reflex bradycardia occurs. As bradycardia is present, it is longest RR interval occurs in this phase. Valsalva ratio is longest RR interval to the shortest RR interval. Normal Valsalva ratio is less than 1.2. Tests for sympathetic. One second, sir. Tests for sympathetic control is blood pressure response to standing, sustained hand grip, and on Valsalva maneuver. On standing, usually from supine position to standing position, the fall in BP occurs, which is rapidly compensated by increase in heart rate in normal individuals. But in autonomic neuropathy, orthostatic hypotension occurs. As the heart rate is not increased rapidly up to the mark. Orthostatic hypotension is defined as fall in systolic blood pressure of more than 30 millimeters of mercury and diastolic blood pressure of more than 10 millimeters of mercury on standing from supine position. In normal individuals, vasoconstriction occurs and heart rate increases, resulting in less than 10 millimeters of mercury fall in diastolic blood pressure. Sustained hand grip. This is another test to assess the sympathetic control. Sustained hand grip causes rise in systolic blood pressure and diastolic blood pressure normally, resulting in increased cardiac output and heart rate. In diastolic, the diastolic blood pressure rises greater than 16 millimeters of mercury, but in autonomic neuropathy, as the abnormal response occurs, that is diastolic blood pressure rises less than 10 millimeters of mercury. The response to Valsalva is in normal individuals on Valsalva, intrathoracic pressure rises, leads to inferior vena cava compression, which causes emptying of blood into the right atrium, leading to initial transient increase in venous return, followed by decrease in venous return occurs. Decreased cardiac output is present. As a result, heart rate increases to maintain cardiac output. Vasoconstriction also occurs. This causes increase in BP. But in autonomic neuropathy, neither heart rate increases or vasoconstriction occurs rapidly to compensate for decreased cardiac output, leading to fall in BP. After release of Valsalva, venous return becomes normal, cardiac output becomes normal, but vasoconstriction is still present. Increase in BP due to delayed vasoconstriction response as a result of autonomic neuropathy. Another test is assessing gastrointestinal autonomic function. Even with mild symptoms, gastroparesis interferes with nutrient delivery to the small bowel and therefore disrupts the relationship between glucose absorption and exogenous insulin administration. This can result in wide swings of glucose levels and unexpected episodes of postprandial hypoglycemia. Hence, gastroparesis should be suspected in patients with erratic glucose control. The finding of retained food in the stomach, even after 8 to 12 hours of fasting, in the absence of obstruction, is diagnostic of gastroparesis. Basic diagnosis tests includes upper GI endoscopy or barium series to rule out structural or mucosal abnormalities of the GI tract. Evaluation of the patient with suspected diabetic gastroparesis might include the following: assessment of glycemic control, medication history, including the use of anticholinergic drugs, ganglion blockers, and psychotropic drugs the patient has been using, and the gastroduodenoscopy to exclude the pyloric or other mechanical obstructions which may cause gastroparesis. Manometry to detect antral hypomotility or pylorospasm. Double isotope scintigraphy is used to measure solid phase gastric emptying. This requires ingestion of a solid labeled radionuclides. liquid emptying gives false negative results. The blood glucose should be normal at the time of testing because hyperglycemia decreases gastric motility. And the test is assessing the pseudomotor function. Testing of the eccrine sweat glands provides the measure of sympathetic cholinergic function as they're supplied by sympathetic nervous system. Thermoregulatory sweat testing assesses both central and peripheral aspects of the afferent sympathetic nervous system from the hypothalamus to the sweat glands, but is not able to differentiate between pre and post ganglionic cause of anhidrosis. Pseudomotor function can be determined by measuring sweat output after iontophoresis or intradermal injection of cholinergic agonist. Tests of pseudomotor function evaluate the extent, distribution, and location of the deficits in sympathetic cholinergic system. Sympathetic cholinergic function. These tests include quantitative pseudomotor axon reflex, which is called QSAR, quantitative pseudomotor axon reflex test, the sweat imprint test, the thermoregulatory sweat test, and the sympathetic skin response. The quantitative pseudomotor assessment test involves iontophoresis of the cholinergic agonist to measure axon reflex medicated pseudomotor response quantitatively to evaluate postganglionic pseudomotor function. 4 sites are generally used to study simultaneously with the patient supine position. The test typically done by recording from the forearm and 3 lower extremity skin sites. It has high sensitivity and specificity and reproducibility with a coefficient of variation of 20% if performed by trained personnel. A sweat imprint may be formed by the secretion of active sweat glands into a plastic or silicone mold in response to iontophoresis cholinergic agonist. This test can be used to determine sweat gland density, sweat droplet size, and sweat volume per area. The thermoregulatory skin test assesses both central and peripheral aspects of the afferent sympathetic nervous system from the hypothalamus to sweat glands. It is a well standardized test and evaluates the distribution of sweat by a change in color of an indicator powder on the skin after exposure to infrared light. The thermoregulatory skin test is semi-quantitative and has high sensitivity, but it has low specificity. However, it is not able to differentiate between pre and post ganglionic cause of anhidrosis. In combination with QSAT, the specificity of the thermoregulatory skin test is increased for delineating the lesion site. The sympathetic skin response or peripheral autonomic surface potential is generated by the sweat glands and overlying epidermis. This response may occur spontaneously or can be evoked by stimuli such as respiration and startle. The sympathetic skin response can be measured with surface electrodes connected to a standard electromyogram instrument. The response habituates with repeated stimuli and is subjected to variability. To decrease this disparity, the stimulus is delivered at irregular intervals, which may minimize the habituation. Thank you, sir. Hello, sir. Hello.
Hello.
Hello, sir. Sir, am I audible, sir?
Yes.
Okay, sir. Okay.
మీ పీపీటీ ఫస్ట్ స్క్రీన్ కనిపిస్తుంది, ఫస్ట్ స్లైడ్.
సార్ స్లైడ్స్ డిస్ప్లే అవ్వలేదా సార్?
డిస్ప్లే అవుతుంది, ఓన్లీ ఫస్ట్ స్లైడే కనిపిస్తుంది.
సార్ ఇప్పుడు మళ్ళీ ఫస్ట్ స్లైడ్ పెట్టాను సార్.
అది ఇప్పుడు వస్తుంది.
ఓకే సార్. సార్ ఇప్పుడు వరకు స్లైడ్స్ డిస్ప్లే అవ్వలేదా సార్?
డిస్ప్లే అయింది, ఓన్లీ ఫస్ట్ స్క్రీనే కనిపించింది అంతే.
ఓ
ఇప్పుడు మూవ్ అవుతుంది.
ఓకే సార్.
ఓకే.
సార్ మళ్ళీ చెప్పనా సార్? Sir, any inputs or changes, sir?
Check with Srikanth, sir. Please continue.
You can just briefly explain everything a little bit.
Okay, madam.
Thank you.
Thank you, madam. Diabetic neuropathy is defined as the presence of symptoms and signs of nerve dysfunction due to prolonged duration of diabetes after all the other causes are ruled out. We are not dealing with the complete neuropathy, man. We are only dealing with the we are going to discuss about the tests which are useful for the assessment of the parasympathetic and sympathetic control. The types of diabetic neuropathy are sensory motor neuropathy and autonomic neuropathy. In sensory motor neuropathy, they are symmetrical and focal and multifocal. In symmetrical type, there is acute sensory neuropathy and chronic sensory motor neuropathy. And focal and multifocal type, they are mononeuropathy, polyneuropathy, small fiber neuropathy, large fiber neuropathy. And in autonomic neuropathy, gustatory sweating, postural hypotension, gastroparesis, diabetic diarrhea, neuropathic bladder, Charcot's arthropathy, and cardiovascular autonomic neuropathy is present. The etiology and pathogenesis is neuronal degeneration occurs due to progressive impairment and regeneration, especially thin myelinated fibers. Neural damage caused by hyperglycemia, which causes the activation of the polyol pathways and synthesis of advanced glycation end products and excessive activation of protein kinase C driven pathways. This causes microangiopathy of vasonervosum. Oxidative stress and alterations in nerve blood flow are other causes. Due to this, transcendental dysfunction occurs as a result of primary demyelination and secondary segmental demyelination due to impairment of axonal control of myelination, remyelination, and Schwann cell proliferation. Atrophy of denervated bands of Schwann cells and basal lamina hypertrophy is also seen. Importance of diabetic neuropathy in anesthesia. The presence of cardiac autonomic neuropathy alters the hemodynamic response to induction and tracheal intubation during general anesthesia. It also gets affected in spinal anesthesia and epidural anesthesia. Grossly speaking, in general anesthesia, parasympathetic control is altered, and in epidural and spinal anesthesia, the sympathetic system is more involved. So, assessment and degree of autonomic neuropathy is important for effective anesthesia management and to decrease intraoperative and perioperative mortality and morbidity. The tests for parasympathetic control are heart rate variability on deep breathing, standing, and on Valsalva maneuver. And in sympathetic, and for assessing sympathetic control, the blood pressure is taken as criteria, and blood pressure response to standing, sustained hand grip, and Valsalva maneuver are assessed. On deep breathing, due to respiratory sinus arrhythmia in normal conditions, and which is a normal phenomenon, heart rate increases in inspiration and decreases in expiration due to vagal input to sinus node. This normal variability is greater than 15 beats per minute. But in diabetic neuropathy patients, this is altered and the maximum variability is less than 10 beats per minute. And on standing, rapid increase in heart rate occurs in normal individuals, and response is maximum after 15th beat. And after standing, and the relative bradycardia occurs after 30th beat after standing. The ratio between the ECG is taken during this phase, and the ratio between the longest RR interval which occurs from 20 to 40 beats, approximately 30th beat, to the smallest RR interval, which occurs in between 5 to 25 beats, approximately 15th beat. And this ratio is normal. Normal ratio is 1.04. If it is less than 1.01, it is considered as abnormal. And on Valsalva maneuver, heart rate increases on release, heart rate decreases. On Valsalva, intrathoracic pressure rises, which causes intravenous inferior vena cava compression, which causes the emptying of blood into the right atrium, which causes initial transient increase in venous return, but followed by the decreased venous return and decreased cardiac output. To compensate this cardiac output decrease, heart rate gets increased to maintain cardiac output, and vasoconstriction also occurs to increase blood pressure. After release of Valsalva, venous return becomes normal, cardiac output becomes normal, but vasoconstriction is still present. Increase in BP due to decreased, delayed response in diabetic neuropathy. Reflex bradycardia occurs. Longest RR interval occurs in this bradycardial phase. Valsalva ratio is longest RR interval to the shortest RR interval. Normal Valsalva ratio is less than 1.2. In blood pressure response, on standing, usually from supine position to standing position, fall in BP occurs, which is rapidly compensated in normal individuals by increase in heart rate. But in autonomic neuropathy, orthostatic hypotension occurs due to delayed response of this heart rate increase. The orthostatic hypotension is defined as the fall in blood pressure, systolic blood pressure of more than 30 millimeters of mercury, and fall in diastolic blood pressure of more than 10 millimeters of mercury on standing from supine position. In normal individuals, vasoconstriction occurs and heart rate increases, resulting in less than 10 millimeters of mercury fall of BP in diastolic blood pressure. Sustained hand grip. In sustained hand grip, causes the systolic blood pressure and diastolic blood pressure normally to increase, and which results in increased cardiac output and heart rate. Diastolic blood pressure rises greater than 16 millimeters of mercury in sustained hand grip. But in autonomic neuropathy, abnormal response occurs, that is, diastolic blood pressure rises less than 10 millimeters of mercury. As we already discussed in Valsalva maneuver, on Valsalva, as intrathoracic pressure rises, inferior vena cava compression occurs, blood is emptied into the right atrium, causing initial transient increase in venous return, which is followed by decreased venous return and decreased cardiac output. Heart rate is increased to maintain cardiac output, and vasoconstriction also occurs. In diabetic neuropathy patients, the vasoconstriction response and heart rate increase response is delayed. It is gradually slow. So in autonomic neuropathy, neither heart rate increase or vasoconstriction occurs rapidly to compensate for decreased cardiac output, leading to fall in BP. And after release, as the response is slow, the vasoconstriction occurs by this time, and it causes the increase in blood pressure. Other tests are assessment of gastrointestinal autonomic function. In diabetic neuropathy, gastroparesis occurs in gas. Even with mild symptoms, gastroparesis interferes with nutrient delivery to the small bowel and therefore disrupts the relationship between glucose absorption and exogenous insulin administration. This can result in wide variation in the glucose levels and unexpected episodes of postprandial hypoglycemia. Therefore, gastroparesis should be suspected in patients with erratic glucose control. The finding of retained food in the stomach even after 8 to 12 hours of fasting of the patient and the absence of mechanical obstruction to digestive tract is diagnostic of gastroparesis. The basic diagnosis test includes upper GI endoscopy or barium series to rule out structural or mucosal abnormalities of the GI tract. Evaluation of the patient with suspected diabetic gastroparesis might include assessment of glycemic control, medication history, including the use of anticholinergic drugs, ganglionic blockers, and psychotropic drugs the patient has been using, and the gastroduodenoscopy to exclude pyloric or other mechanical obstructions. The manometry is used to detect the antral hypomotility and pylorospasm. The double isotope scintigraphy is used to measure solid phase gastric emptying. This requires ingestion of a solid labeled radionuclide. Liquid emptying gives false negative results. So solid barium meal studies are used. The blood glucose should be normal at the time of testing because hyperglycemia decreases gastric motility. Assessment of pseudomotor function. So to assess the pseudomotor function, the eccrine sweat gland function is assessed due to as they are mainly innervated by a sympathetic cholinergic system. Thermoregulatory sweat test assesses both central and peripheral aspects of the efferent sympathetic nervous system from the hypothalamus to sweat glands, but it is not able to differentiate between preganglionic and postganglionic cause of anhidrosis. The tests used to assess the pseudomotor function, the eccrine sweat gland function are quantitative pseudomotor axon reflex test, the sweat imprint test, the thermoregulatory sweat test, the sympathetic skin response. The quantitative pseudomotor axon reflex test involves iontophoresis of the cholinergic agonist to measure axon reflex, medicated pseudomotor responses quantitatively to evaluate postganglionic pseudomotor function. Generally, 4 sites are used and studied simultaneously with the patient in supine position. The sites are one on the forearm and the other 3 in the lower extremity skin sites. This has high sensitivity and specificity with a coefficient variation of 20% if performed by the trained personnel. A sweat imprint test may be formed by the secretion of active sweat glands into a plastic or silicon mold in response to iontophoresis of a cholinergic agonist. This test can be used to determine sweat gland density, sweat droplet size, and sweat volume per area. The thermoregulatory skin test assesses both central and peripheral aspects of the efferent sympathetic nervous system from the hypothalamus to sweat glands. It is a well standardized test and evaluates the distribution of sweat by a change in color of an indicator powder on the skin after exposure to infrared light. The thermoregulatory skin test is semi-quantitative and has high sensitivity, but the specificity is low. When this QSAT and thermoregulatory skin test are done and assessed, the specificity of the thermoregulatory skin test increases in combination with QSAT test. The sympathetic skin response on peripheral autonomic surface or peripheral autonomic surface potential is generated by sweat glands and overlying epidermis. This response may occur spontaneously or can be evoked by stimulus such as respiration or startle response. The sympathetic skin response can be measured with surface electrodes connected to a standard electromyogram instrument. The response habituates and gets habituated with repeated stimuli. To avoid this, the stimuli are delivered at irregular intervals to minimize the habituation. Thank you, sir.
Hello,
Hello, sir.
good morning.
Good morning, sir.
How do you prevent autonomic neuropathy?
Sir, to maintain glycemic levels, sir, because due to hyperglycemia, the polyol pathways and protein kinase C pathways are activated, sir. So, by maintaining glycemic control, diabetic autonomic neuropathy can be prevented to some extent, sir.
Good. What is the normal glycemic control levels, fasting and postprandial?
Sir, fasting up to 120, 120, sir, and postprandial up to 180, sir.
What is tight blood glucose control and where it is indicated? Hello?
Hello, sir.
Tight blood glucose is indicated in CT surgeries, sir.
Okay, sir. Okay.
Fasting below 110 and postprandial below 160.
Okay, sir.
How do you rapidly control blood glucose level? If a patient comes with a blood glucose level of 450 or 500 and you want to take him to surgery,
Yes, sir.
rapidly you want to lower the blood glucose level, how do you do?
Sir, we give insulin with potassium chloride, sir, because as we give insulin, the potassium shift occurs, and to compensate that, potassium chloride is added, sir.
How much you give? Oh, that regime, what is the name of that regime you were talking about? Usually we practice insulin infusion. We
Yes,
make
sir.
1 ml is one unit insulin, and according to blood glucose, every hour blood glucose estimation,
Okay, sir.
you will adjust the insulin infusion rate.
Infusion, sir.
Thank you. Good presentation.
Thank you, sir. Thank you. Any other inputs, sir? Any other inputs, madam? Oh, okay, sir. Okay, sir. I'm closing the presentation, sir. Thank you so much, sir. Thank you so much, ma'am. Thank you all.
అందరూ వస్తారు కదా, ఎవరు లేరు. స్లైడ్లు మూవ్ అవ్వలేదు. నువ్వు ఇక్కడ మూవ్ చేస్తున్నావు, నేను ఎక్కడి నుంచే చూస్తున్నాను. ఇది చూసే కదా నువ్వు చదువుతున్నావు.
సార్, ఇందులో మూవ్ అవ్వలేదు సార్. అది ఇంకో 4 వారాల దాకా నేను చెప్పక్కర్లేదు.
4 వారాలు కదా, 4 నెలలు.
టైం ఎక్కడ అయిందంటే సార్, మేడం వచ్చి వాళ్ళు ఇంకొకసారి చెప్పమన్నారు సార్. దాంతో
మీ ఫోన్ ఇస్తాను కదా. అయ్యో ఎందుకు? ఏమైంది? పేషెంట్ రాస్తాం కదా నన్ను.
పాపను కుట్టినాడు. పాపకాయ మంచిగా ఉన్నాయి లేదు మేడం.
అదే ఏదైనా కానీ మరి పాపకు చేయాల్సి ఇంటిమేట్ చేస్తా ఉండి మరి తప్ప చేయకపోతే చచ్చిపోద్ది, తప్పదు కదా. డయాలసిస్ చేయాలి తనకి. అమ్మా డయాలసిస్ టెక్నీషియన్స్ చెప్పేసి డయాలసిస్ శంకర్ని పిలిపించండి, ఒక్క షార్ట్ డయాలసిస్ చేయించండి. ఇంకొకటి బీపీ తక్కువ ఉంటది,